Okay, so thank you very much. So I hope to build a little bit upon our earlier speakers in this sphere, although the topic itself does not seem clearly linked to joint homeostasis and obesity. I do appreciate the earlier speakers' work. A lot of my effort in osteoarthritis has focused on understanding the pathogenesis and then on trying to take the science and to emerge with more successful treatments that will allow for joint homeostasis, not only when we have one insightful clinician and his colleagues, but to have this as the more normative idea. So a lot of my work early on did focus on the joint, either on the metabolism or the neuromuscular processes. What was mentioned was the motor firing of muscles around a joint, and I did a lot of work on showing normal and abnormal firing and the implications for the joint health. A lot of work on proprioception, looking distinctly at those nerves, and then possibly when one pokes around in cartilage, having no nerves, we might assume that there's actually nothing going on, but there might be something very active. I was working at the Hospital for Special Surgery for several years as a research fellow, and I came there, I think, with very limited ideas about osteoarthritis and the fact it was a joint-related, very specific problem, and you would isolate your treatments to kind of fixing the local lesion. I was very surprised in this very elite hospital to uncover individuals who had a variety of arthroplasty surgeries, most of whom were relatively healthy and at the high end of the socioeconomic spectrum, and finding that their outcomes over time were not as optimal as the surgery itself would have predicted. When I had the opportunity to look at more than 1,000 cases of hip osteoarthritis and their outcomes, I was very surprised when I looked at the baseline data to observe depression, which had not been treated but was clearly a clinically visible comorbid disease, or was a reactive expression of patients entering the facility, which appeared to have a very strong trend relationship to the magnitude of the outcomes. I later had the opportunity to look at this cohort I'm going to describe today, and I've selected individuals who represent a very mild to moderate form of knee osteoarthritis, who are community dwellers, 60 years and older, who try to take part in an exercise-related intervention, were clearly motivated, but I found that the outcomes of that exercise intervention, again, were not as successful as one might predict, and I wanted to look at predictors of baseline actual clinical presentation, and to see and anticipate what else we might learn from this. So we have heard here, and we're going to hear more today. This is not our only rheumatological concern, but it does involve most of the day-to-day visits to orthopedic and rheumatology departments. And there are definitely varying degrees of unrelenting pain, in my estimation, some excess suffering, and then maybe deleterious outcomes which could have been prevented. And the standard method of approaching this from a physical therapy point of view and a medical point of view does not always really correlate with actually the complaints of the patient and their outcome. The recent research has tried to not only envision joint health, but now looks at the body as a whole, and is looking at especially the central nervous system as a kind of untapped area for maybe helping us to understand either excess pain that is not reflected in the MRIs or the bone scans, or that which is refractory to regular analgesic intervention. So there's a lot of related research that talks about the link between depression and chronic pain in other spheres, and I had this data which I could look at retrospectively and decided to examine the magnitude and extent of depressive symptoms among this relatively healthy cohort to establish first if this is an important potential correlate, and if so, how does it associate with important health outcomes such as mobility, the ability to adhere to exercise programs or be motivated, as well as to pain and its management. So based on my previous analysis with the hip osteoarthritis cases and a burgeoning literature in this area, it is clearly, we have a biological disease, but we have many psychosocial or psychological factors that may explain the inability to observe positive outcomes when we simply deal with the biological and the physical. So this is a very rudimentary, explanatory model which suggests that the main influence depression might have is on mediating or moderating pain, mobility, and the willingness to participate in exercise, and this very well-studied psychological correlate, self-efficacy, which is an idea that relates to a person's belief in their ability to be able to conduct a specific behavior, such as exercise behavior. And those who believe they can do it are more likely to intend to do it and carry it out and stick to it. Those who feel less efficacious are less likely to do it, and that has implications for rheumatological patients, including rheumatoid arthritis, fibromyalgia, etc. So the idea here is that knee osteoarthritis, which was diagnosed based on radiographic standing x-rays and some of the clinical symptoms, together with varying degrees of pain, produces some level of functional disability, and the degree to which this impacts the person either actually or symbolically might cause some reactive depression symptoms, and this is over and above comorbid depression, which was not evident in this group. In turn, someone who feels depressed, including helpless, very fatigued, very sad about their situation, might feel more helpless in being able to undertake the necessary self-management, which becomes a perpetual cycle of further depression and pain and further disability. So the cohort that I was able to look at numbered 86. There was a mix of unilateral and bilateral cases. We'll see in the long run the data on depression were not related to the degree of disability being unilateral or bilateral. We used a traditional visual analog pain scale, a subjective scale, the arthritis impact measurement scale. We specifically have focused on the meaning of the actual disease to the patient on a scale of 1 to 10, 10 being that there's a severe impact, and 0 mean I do have this problem, but it has no real impact. The CESD depression scale, the Centers for Epidemiological Studies depression scale, a very well-known validated scale going from 0 to 60 with a cutoff point at 16. It doesn't measure direct depression, it measures symptoms of depression which are potentially explanatory of a depressive state. Traditionally, we measure different walking velocities, self-paced and a fast walking velocity. We did a 6-minute walking endurance test and measured perceived exertion during that test using a 1 to 11 Borg scale. And then Kate Lorig's arthritis self-efficacy scale, which has 3 categories. We used the pain category, which has 5 items, and the symptom management has 6, such as, are you able to manage your feelings of sadness? Are you able to manage your fatigue? Are you able to manage the pain to the degree you would like? So some of the results show that in terms of the degree of pain and impact, this cohort could really be said to be very moderately or mildly affected. If you look at the osteoarthritis literature, there is much evidence people score 7, 8 or so on these visual analog scales to represent their pain. Their ability to walk a reasonable distance in 6 minutes without assistive devices suggested this was not a highly disabled group. And we were interested in this because if we can find some linkages early on that might be predictive of what we should do later, I think we'll be in a better position than adding something on once the person is really in a very severely impaired state. What was interesting was that the CESD scores of 16 or higher occurred in over 25% of this cohort, none of whom had an actual diagnosis of depression, although a majority had some kind of possible obesity problem. The actual average obesity level here was 28, which is categorized in the overweight area, and we did have some who were actually had a BMI of 38, 39, or 40, which was characterized early as being severely obese. That was the characteristic here. This cohort, however, also, although young community dwellers, otherwise affluent, expressed less than 100% confidence. In fact, only 56% were actually, most were not confident, and that is 56% were not confident in actually managing their pain or symptoms. When we looked at whether the depression scores are correlated with important clinical measures, we found significant correlations in the direction we would predict. That is, depression was correlated with pain and impact, meaning the higher the depression score, the higher the pain and impact. It impacted inversely on the walking speed, either at a fast pace or regular pace, which is an indicator of functional ability and future falls, etc. And it most strongly correlated with the perceptions of individuals of how confident they were to manage their pain or health condition. These 2 slides simply represent the fact that there seems to be a trend relationship between the degree of depressive scores and the confidence people have when you break down depression symptoms into none, mild, moderate, and severe. And this was similar for both of those scales. We also tried to look at what is the best predictor of these depressive symptoms in this population. Was it pain, as we really thought would be the case? Was it the limited walking distance? Was it the breathlessness? However, the single correlate that stood out was the individual's own perception of their ability to manage their fatigue and pain and other self-management practices, such as adhering to medications and exercise. So this study and subsequently several others have confirmed there may be a high percentage of adults with mild to moderate osteoarthritis visiting the physician maybe for the first time. And of course this would magnify in those who come subsequently, who present with depressive symptoms, do not discuss them since this is viewed as a physical or biological disease, and these remain undiagnosed. However, some of the magnitude of these symptoms are associated negatively with pain, functional disability, and their ability to cope successfully and confidently on a regular basis with their condition, and specifically those who feel unconfident will tend to have higher scores, which translate into greater disability. So the conclusion here is that although frequently neglected, it is very possible identifying depression through standard screening process, if observed early, could be intervened upon, and at the same time, when individuals are working with physical therapists and others, it may be very important to discern what type of confidence they have in their ability to undertake the recommendations, because you can strategically build a person's confidence through taking small steps and feedback, etc. And maybe in the long term, that paradigm reinforces the situation so joint health can emerge. Some of the views held by current researchers in this area, again, emphasize routinely assessing patients for depressive symptoms using the CES-day or one of the other inventories. Also examine the person's confidence to carry out the instructions, especially those related to general self-management, and follow this with maybe multidisciplinary interventions, including exercise, the cognitive behavioral strategies, social support, and corrective feedback. Not only do we anticipate and have Professor Lin has shown decrease in pain severity and arthritis impact, improved adherence to self-management strategies, including exercise, and decrease in healthcare and personal human costs. I also want to emphasize there was no discrimination here among the cases who were obesity and more or less depressed. One of the very strong factors or the reasons why obesity is an additional problem is it's very correlated with high levels of depression, either as a cause or an impact. And in this study, almost everyone was already overweight, so we might not have had enough variance to tease that out. Possibly working along something along these lines as a theoretical framework, testing this in the field will enable us to advance the case for many of these arthritis sufferers who either believe nothing can be done for them or are surrounded by others who've had disadvantageous opportunities, and maybe then the norm and will become joint homeostasis and well-being. So thank you.
Thank you.
All right.
Do we have any questions?
Any questions?
From the panel, yes.
Dr. Ray, thanks for a very effective presentation. I'd like to just ask you, with regards to the overall psychological well-being, I mean, we've obviously identified that the overall sort of patient population that we see in clinics with osteoarthritis who are listed for surgery have got a lot of other factors that overall determine their outcome. And I think this has been sort of recognized in a few studies that have come about. Are you aware of any sort of prospective studies that are being done with psychological scoring used as a factor to predict or actually choose your winners, if you like, following surgery?
Yes, this is really a retrospective analysis, but I recently did look at what has been done with prospective studies and before and after measures in surgery and with different populations, and it seems that the pre-existing depressive scores or inventories that denote well-being are highly predictive of outcomes. And so current papers in 2014 for surgeons, for example, they might want to look at well-being and depression before the person goes to surgery, and if necessary, expand the window for some intervention, raise their well-being, because the outcome in terms of either duration and seriousness will be reduced based on quite a number of studies from different parts of the world.
As a surgeon, back when I was doing total knees, I would get a sense of a patient who was kind of depressed, just as a gestalt sense, and knew that this might be a problem in the future. But I admit that I didn't have any kind of sensitivity to the kind of studies you're talking about. It was your experience that most of the surgeons are oblivious to what you're talking about, and say you did a screening and found somebody who was over 16 on the scale you're talking about, or whatever characteristics you indicate that put the patient into a at-risk pool of increased depression and so forth. Once you identify that group, what's your advice of what to do about it in particular?
All right, I think there are a few things. There definitely are increasing numbers of professors and those who work in the field who are now asking for a routine screening in the event you sense it, but it might not be the priority. With electronic records, it might not even be something that gets recorded, but they're saying, look at it. Based either on the CSD, the HADS, which also looks at anxiety, which I looked at separately, which seems to actually heighten the problem as opposed to depression in some sense. And if you find that the scores are symptomatic of something which could be treated, it doesn't necessarily warrant medication. But I think recognizing depression, especially reactive depression, can minimize that depression and anxiety. And then, if necessary, there could be other correlates. Cardiovascular disease that is undetected. There are other correlates of depression that may have existed for some time, and maybe the right psychologist or referral is really worth the trouble to see whether this is a clinically significant depression, or the nurse practitioner or health educator can alleviate the anxieties and the expressions of depression. But there is a concerted movement, and I notice it from surgeons in Britain, a number of surgeons in the United States, in Europe, and Australia who notice that there is obviously something here that we should try to maybe standardize in order to be able to direct the clinician appropriately.
Do you find the patients are receptive to this? Because I can just sort of see some patients, what, you think I'm nuts? I'm going to go to the shrink before you do my surgery? I can see that response in some.
I think the reverse might be is that some of those who expressed in this cohort on the charts to the nurse, I feel very anxious about the surgery, I feel suicidal, I'm only 60, and I think they would probably be receptive. Some others, we might say your surgery is likely to be enhanced and the time frame short, and your pain levels might be decreased, because this is very underestimated. And I think it's the way you communicate this. People today understand that holistic health and well-being is what the goal of the surgery is. Obviously, if the person is as reticent, that's fine, but we would still then cover ourselves on our chart to say this was discussed, and the person has agreed that they do not care about the outcomes and they absolve you. Whereas you don't want to be caught now that people have advocated for this. Someone says, I was depressed, you did the surgery or gave me something I wasn't capable of doing, and that's the cause of my demise.
I think your insights are very, very important. I think the patient's understanding of what's going to happen, particularly the point you just made, total knee replacement surgery is big goddamn surgery, and most they walk into it, oh, I'm going to get a brand new knee, and it's no big deal, and a lot of the surgeons kind of put it this way, and in fact, it's a huge big deal, and to prepare them appropriately and to modify them appropriately with their concerns and so forth, I think it's a very important thing. I applaud you.
All right, so thank you, and I think you will get the joint homeostasis more effectively if people do not have this unrealistic belief that the 60-year-old is now getting the 16-year-old knee and is going back to, ice hockey. I'm from Canada, so that's what would be the goal. And I think they would appreciate the whole joint health and body health, because when one joint is sore, your health succumbs. You can't do the exercise, you put on weight, then it's very hard, even if you get the chair, to do the lifting. All right, so thank you all.
More questions? I have a quick comment, if I could, and perhaps you could respond to it. One of the things that Dr. Dye talked about is that this rapid rehab, getting people back out there, may not be the best thing. That in reality, to get to the homeostasis, more rest or other therapies are required. That doesn't jive with the average American methodology of getting better. We look at schedules and we think that if we're faster, we're better. So it would seem to me that there is at least a possibility that if someone says, "Oh, I've missed month number 6's goals," that their depressive state is going to increase, and thus the rehab is going to suffer rather significantly. So my thought, and you can certainly comment on this, is that how we manage these expectations within the patients so that they understand that at month 4, 5, 6 and a half that their rehab is actually going properly and they shouldn't be depressed. But I'll leave that comment for you.
Right, I think it's very important, patient education, keep up with the science, and that the outcomes, particularly in terms of the costs and the morbidity and the many failures of surgeries to address problems, and then many of these cohorts have subsequently gone for second surgeries or hip replacements when in fact the attempt to do something rapidly and fix the problem is not occurring. I think people today are very savvy in the network. I have a doctoral student who said her father has to go for hip surgery, but now they are consulting the network to see whether there are maybe some problems people encountered and who might give the more clear case of a paradigm. And I think patients today are computer savvy. They want to maximize their health, and if you give them some science, as well as physicians don't want extra work and revolving doors, they want to minimize the fallout. Maybe it's a slow paradigm shift, but if it's cost savings, even in the companies, if we can show a return on the investment, you save money and you have more creative workers who are not in pain and miserable, we have a societal benefit. Mm-hmm. But that's for all of you. That's why you're here, to raise the bar for ourselves when our joints break down. Mm-hmm.